Good afternoon, everyone. Good afternoon. Good afternoon. And how are you? Thank you so much for joining us. We are at session number 3 in our series. It's wonderful, wonderful to have you joining us for the third session. And we are going to start. Our apologies for being just a little behind schedule. So let us get a few preliminaries out of the way. You'll get your official welcome, but I just want to say thank you for joining us for session 3. My name is Cheryl Garrix Lloyd, and I am president of the Omega Kappa chapter of Sigma. And we are embarking on education and sharing and many other things. You'll hear a little bit more about it when we get to the end. So a little housekeeping first, please. A reminder, you need to join the Zoom session with your full name as you registered. Please, if you are in here and you are not using your full name, we are going to put you in the waiting room. If you don't know how to change your name, you should be able to hover over yourself where you've joined the session. There's a button on the right-hand side that says more. When you click more, it gives you the rename option and you can rename yourself. Please also ensure you are registered for today's session, because if you're not, we're also going to put you in the waiting room. And we ask the persons who are joining here in Zoom to come in. You're already in with your full names. The persons who are joining us in YouTube land on our channel, we thank you. Over in YouTube, please ensure you put your name in the chat so we can have a record of your being in the live session. So with that being said, and while some people are working on some things, we always start off with a little activity to get our brains popping and ready to hear what our presenter has to say. So for those who joined me before, we also have a little prize, and we ask you to listen up keenly in the presentation for another little prize at the end. So get your paper and your pencil, because we still do old-fashioned, people going to say, but if you're using the notepad on your phone or on your computer, that's perfectly fine. You're going to have to listen to how it works. Do not put your name in the Zoom chat. So let me put out the disclaimer. Moderator and presenter are not eligible for the prize. They can do the activity, but not the prize. Yes, moderator, never mind. However, it means that we are asking you, when you get your paper and your pencil or your notebooks and your notepads ready, listen out for the instruction. It's going to be 1 single minute. I'm setting the timer, that's how it works. And in that minute, we're going to ask you to do whatever the activity is that we have for this afternoon. When the 1 minute is up, type in the chat, either over here or over on YouTube, how many of what it is that you found. We don't want you to put the answer. We want you to put how many. So for instance, if it's math or if it's even words, say 4 words, 5 words, 6 words. And then I'm going to put my number in the chat on both sides, and you have to send me the evidence, the picture of what you find, because we do evidence, we're nurses, yes? So listen up again, because it's coming up. The instructions are, get your pencil and your paper ready. We have something planned out for you. You're going to get 1 single minute. And when you get that minute, you're going to solve whatever it is. As soon as you solve it and the 1 minute is up and I say time is up, start typing your answers in the chat. Put in there how many of what you found. And then after you've done that, as we go along, I'm going to put my number and I'm going to say to you, please ensure you send the picture evidence. All right? Let me hear you if you are ready and you have the papers ready and you're ready for us to get the brains kicking. Who is ready?
Ready.
All right. Is everybody seeing my screen?
Yes.
Wonderful. So the 1 minute is going to start shortly. Anybody needs me to repeat the instructions really quick to make sure you hear me? Anybody? All right, so that means everybody understands. So we as Omega Kappa chapter of Sigma welcome you, and we are going to move right into the activity. I'm going to start the 1 minute. Today we are doing another worded one, so to speak, but you're going to get the 1 minute to write the answers on your paper. When you are done, you're going to write how many you solved in the chat, and then you're going to have to send your evidence to us. All right? Everybody ready? Let's go. All right, 1 minute has started. Go. I think you get too much time, you know. 5, 4, 3, 2, 1. Time is up. Pencils down. So now, type in the chat for me. How many did you solve? Not what you got, how many? There were 9 of them on there. How many of them did you solve? Put those in the chat, and then we're going to ask the person who has the most to send their evidence so that we are able to verify who has won the prize. Thank you all so much for participating. Look out for the phone number in the chat. So this afternoon, we have another interesting presentation for you. And we have our lovely chapter member, Miss Denise Morris, who's moderating today. And she will be telling you the official welcome and what's going to be happening and introduce our speaker. So thank you again for joining us. And over to you, Madam Denise.
Hello, pleasant good afternoon and welcome. We are in number 3 of our series in the infection prevention and control and the non-nursing webinar series, and this is number 3. Coming to you today is Miss Denita Johnson Wallace. She's a family nurse practitioner, and she's going to be talking about the elimination of the transmission of STIs from mother to child. So I'm going to move on and introduce her so we can get started. So Mrs. Donita Johnson Wallace is a graduate of the Hampton School in St. Elizabeth with 27 years of unbroken service in the field of nursing in Jamaica. She started her nursing career December of 1993 as a registered nurse at the Black River Hospital. Soon after which she obtained the certificate in midwifery. In 1999, she pursued the family nurse practitioner course, and after completion, she was employed by the St. James Health Department. As a graduate nurse practitioner, she became involved in the area of HIV and STI management through lunchtime by liming with the infamous nurse practitioner Iris Wilson at the St. James Health Department. Her passion for HIV STI management continued to grow, resulting in her assuming the role in the parish HIV/STI program coordinator for 2+ years. As a result of her continued interest in HIV, she completed the following: postgraduate diploma in the management of HIV infection in 2016, certificate in clinical management of HIV infection in 2020, certificate in project management in global health in 2021, certificate in monitoring and evaluation in global health in 2022, certificate in leadership and management in global health 2020. That is going to be done soon. Mrs. Johnson Wallace has hailed as her greatest successes in the Western region the increase from 3 to 6 adult HIV care sites, resulting in at least one site per parish. That's awesome. Among the many awards received, Ms. Johnson Wallace received recognition for the following. In 2016, High Individual Value Award, National HIV Program. In 2017, the Minister of Health HIV Award for Leadership and Excellence. In 2018, Long Service Award for 25 years of nurses service, the government of Jamaica. In 2021, the WRHA received 3 top awards at the annual Treatment Care and Support annual review. And her long-term goal in the HIV response is to realize complete integration of the HIV program into the family health program, delivering optimal HIV care services in each health district per parish. I'd like for you to welcome Ms. Danita Johnson Wallace.
Good afternoon, everyone. You can open your microphone and just say good afternoon so that I know you're hearing me.
I'm hearing you fine. Just one quick
Good
thing,
afternoon.
please.
Good afternoon. Good afternoon.
Good afternoon.
Thank you, thank you, thank you.
One quick thing before you start, if you guys have a cell phone, if you can silence them and keep yourself muted until Q&A opens up. Thank you.
All right. STIs, prevention of mother-to-child transmission of sexually transmitted infections. It's a very long topic. I hope we can cover same within the time allotted. If at any point in time we want to take a 2-minute stretch, cycle body stretch where you spin your roll from top to bottom, and we just want to take a stretch. If you think you're hearing me for too long, just unmute and just say, let us take a stretch at some point. I appreciate the break every now and again. So thank you. Thanks to the Omega Kappa chapter for asking me to do the presentation on probably one of my fondest and favorite area of, I'm going to use the word medicine, because yes, it does involve some amount of nursing care, but I would have been aligned to this based on being a family nurse practitioner and actually treating patients with sexually transmitted infections. So, right, so at the end of the presentation, I want us to be able to actually define what is PMTCT, and I'm shortening this to mean prevention of mother-to-child transmission. What are the selected sexually transmitted infections? What are they? Highlighting the prevalence, the clinical presentations, clinical management, and what are the complications if left untreated or inadequately treated. Ways to prevent mother-to-child transmission of these STIs, and the elimination of mother-to-child transmission of HIV and syphilis, the history of it, and where are we as a country in Jamaica at this time. So mother-to-child transmission is really the transmission of a virus or any infectious agent to the young child or unborn baby during pregnancy, during delivery, or at breastfeeding. So it's the transmission of. And so you'll hear persons refer to vertical transmission or horizontal transmission. Mother-to-child transmission is really vertical transmission from mother to child. Horizontal is, if you picture what is horizontal and what is vertical, horizontal is side by side and vertical is top down. So it's from mother to child, bigger person giving it to the smaller person, and horizontal is side to side. So it could be a brother and a sister, a man and a woman, whatever it is. So when you think of the term, so you may be in some spaces and they say vertical transmission, we're really talking about mother to child transmission. But if you say horizontal transmission, it's from man to woman, woman to woman, or man to man, but it's like across the plane on the same level. So what are sexually transmitted infections? And I don't like when my thing is at the top, right? So sexually transmitted infections are diseases capable of spreading from person to person through sexual contact with the exchange of bodily fluids such as semen, blood, vaginal secretions, and non-sexual contact with use of inanimate objects. And there is also mother-to-child transmission, blood transfusion, and or IV drug use. Just one point to mention here that when we refer to sexual contact with exchange of body fluids, some persons think sexual contact is really only sex from penis to vagina, but it also involves penis to mouth, anywhere the point of contact takes place. And so just sitting on a person's lap, close contact, you may be able to get simple herpes, may be able to get scabies, which is a STI, because of the root of the transmission. So it is really just sexual contact or coming in contact with the individual in that. So it's not about mouth, it's not about vagina, it's not about the method of sex, it's just the act of sex. Prevalence for STIs, and we're looking at it internationally. I think I have a slide on it in Jamaica. So data published in 2019, it may be dated now. We have over 1 million STIs acquired every day worldwide. Annually, there's an estimated 376 million new STIs, with 1 of 4 STIs being the causative organism. So annually, there's an estimated 376 million of new cases of either chlamydia, gonorrhea, syphilis, and trichomoniasis. And too often we are in clinical spaces and persons come in, or sometimes I'm asked to do presentations probably of this sort at a church or social activity, and persons say they don't know that, because everybody speaks about HIV. So we believe that gonorrhea has died a natural death, or it no longer exists. And trichomoniasis, what is that? So people think that STIs are a thing done away with and we only have HIV. Some persons may still think or know that we have syphilis happening. Over 500 million persons are estimated to have genital infection, and especially herpes simplex infection. It was thought that herpes simplex was associated with herpes infection in the mouth, and herpes, the genital herpes was the type 2. But because of the practice of oral sex, you may have one versus the other, or one transmitted to the other during the sexual contact. And so, over 290 million women have human papilloma infection. And just of note that we have over 100 types of HPV, subtypes of HPV infection or germ. And so we know that, for those of us who might know, and just for information, we have type 16, type 33 being most commonly associated with cervical cancer, and then types 11, 14 most commonly associated with genital warts and penile cancer. So it depends on the type. And so that's the HPV vaccine then is created, and I think it provides coverage for type 16, 33, because those are the main common type for cervical cancer. So it might not prevent genital warts, but it may prevent cervical cancer. But there are some, and so it depends on when you are looking around or shopping around then for HPV vaccine, you need to look at the one with a wider coverage. It may not just cover just 16 and 33, but it may cover 11, 14, 18, 16, the one with wider coverage. In Jamaica, using the EPI info for 2016, between 1982 and 2016, 41% of persons living with HIV had a history of sexually transmitted infection. HIV infection amongst STI clinic attendees was 3.3%, with the 20 to 49 age group most commonly infected. There's this saying, this old adage that says, two don't walk unless they agree. If somebody shows up at your facility with HIV, they had an STI. And if somebody shows up at your facility with an STI, sore in the vagina or discharge from the vagina, have them tested for HIV, because two don't walk unless they agree. And we see that the 20 to 49 age group is the most commonly age group affected. Why? Because at this age, persons are independent and they think they have established a trusted relationship. And so they tend to think that, okay, I can have sex with my partner because I think, in my opinion, this is the one partner that I have. But this is the age where persons explore and they prove macho how many partners you can have. And so a man may have more than one woman, and a woman thinks she's the only one. And so because she is confident in her partner, she doesn't think condom use. And also this is the age where persons think that they want to have family. And so sex without a condom would be the wisest thing to do, because I mean, if you use condom, you can't get a woman impregnated. So this is at the risk at the greatest time of having the STIs. We might find that we have more persons now in the 15 to 29 age group because persons are initiating sex much earlier. But at the time, that was what was recorded. And when we look at STIs, STIs are treated and are classified based on what they do cause. So I'm not just doing STIs overall, because if I were, apart from vaginal discharge syndrome, I would have had to mention urethral discharge syndrome. So you have vaginal discharge syndrome in women, and you have urethral discharge in men. Both parties do have genital ulcer disease. And so for the purpose of this presentation, I am looking mainly at vaginal discharge syndrome and genital ulcer disease. So when we look at vaginal discharge syndrome, why? Syndrome meaning a group of symptoms. There is reported increased vaginal discharge, usually associated with odor and color. It's general and it's normal for the vagina to produce secretions. Just like your mouth produces saliva, your vagina produces secretions. This secretion should be, depending on the time of the month, clear or white, doesn't itch, doesn't smell. For some people, they may tell it smell raw like an egg white, or, but there's always a presence of discharge. It may be heavier when the woman is ovulating or just after the period, but there is a discharge. However, when it becomes associated with an odor, a malodor that is, or the color has changed, then we definitely know something is wrong. There may be also associated vulvar and vaginal itching. Vulval itching on the outside, but in deeper section, vaginal itching. There may be burning when the woman passes urine. There may be pain when she has sex. So that's dyspareunia. And in the most common causative agent for the vaginitis would either be Trichomonas vaginalis, bacterial vaginosis, and that's supposed to be vaginosis, candidiasis, and you may have incervicitis. So this is where it is deeper, further in. You may be cervicitis. Cervix is now involved. There's gonorrhea and chlamydia, and also herpes. So when we look at gonorrhea, as I said, although trichomoniasis, bacterial vaginosis, and candida are common symptoms of vaginitis, there really isn't a transmission of mother to child of any of these infections. So for the purpose of the presentation outline that I'm following, I'm really looking at gonorrhea. So gonorrhea caused by a bacteria, Neisseria gonorrhea. And I want us to bear in mind, because of bacteria, it can be treated with antibacterial. So it's not a virus, it's a bacteria. A gram-negative Diplococcus, double-stranded, typically infects the epithelia of the urethra, the cervix, can even affect the rectum. And I'm gonna use the throat, because if the woman has oral sex or man has oral sex with his partner, then yes, so anywhere the source of contact is, it can infect, causing irritation, pain, and a purulent discharge. And the very same discharge that you will see for a woman in her vagina, a yellow discharge, you will see the same thing in the throat. So the woman may have what we would call a sore throat, and there's pus on the back of the throat, the tonsils. It's the very same thing for the vagina, the very same thing for the rectum. So urethral and cervical infections are most common, but infections in the pharynx and the rectum can occur after having anal and or oral sex with an infected partner. The symptoms may appear in 10 to 20% of women and may include burning when they pass urine, dysuria, vaginal discharge. Before examination, what I will tell you, a man will complain of the discharge and or the burning within 3 days of having sex and picking up gonorrhea. A woman may take a longer time to have symptoms, and some women may not have any symptom at all. So the man will say he's going home to kill John Tom because he got something from her. Chances are she doesn't even know that she has the discharge there because it's deep up inside of the vagina. And so until she starts experiencing dysuria and or the vaginal discharge, or the man picks up something and goes to the doctor and comes back and tell her, then she may go get examined and it's found. On examination, you may find that there's a mucopurulent discharge. So mucoid and purulent mean, what is the word, pus in the vagina and or coming from the cervix itself. The cervix may be red and or when you touch or just simply putting in the speculum, you may find that there's bleeding on contact. And at the bottom of this photo, this slide, I've put a picture there for you to see a bleeding, what I'm calling a bleeding cervix and the discharge edged within the grooves of the cervix. So there again, purulent urethral discharge, and the one may end up having a pelvic inflammatory condition because the infection tends to travel up. So although it might have started inside the vagina, it travels up through the cervix, to the through the womb, to the fallopian tubes. And so on examination, you may find that there's tenderness in the tubes when you do your bimanual examination. So there's salpingitis, dyspareunia, tenderness on palpation of the abdomen, adnexy, and or cervix. And a vaginal examination is not complete until you have done your bimanual examination. A lot of persons tend to ask the patients to pull the underwear down so that I can see the discharge. Oh yes, there is. Just for educational information is that even if a woman has a normal vaginal discharge, it goes onto the underwear. There is dust on our body because we're all human made from the dust of the earth. We bathe, but we walk in, we sweat, etc. The dirt from the human skin, the hair fold, can change the color of the discharge. Ear again can also change the color of the discharge. So simply looking at a discharge is not diagnostic of an STI. And if you want to identify if there's any involvement in any of the organs, the abdominal organs, then you definitely have to do a bimanual examination. And so how do we treat gonorrhea? So what we found out is that before my time, and I'm not dating myself, before my time, everybody would use black and red tablets. And for those of us, I'm sure we hear of black and red, and then there was a time when it was red and cream color capsule that persons would just go over the counter, but those have been abused, and so we have resistance to those, and those are ampicillin drugs. So ceftriaxone is the recommended now, plus azithromycin, macrolide, azithromycin, 2 grams stat, and or you may add doxycycline or metronidazole or any of those that, because I have to be shifting the, so I'm hoping you're able to see below, ciprofloxacin. So any one of these here that individual can take, because we're treating, we're doing syndromic management. You want to know that when you treat somebody for gonorrhea, you want to just cover them in the event that there might be chlamydia or there might be trichomoniasis that is happening, because they can have a mixture of the disease. So when you give the metronidazole, you're covering the trich, and or for the chlamydia, you're using the azithromycin to cover that, and for the ceftriaxone, you're covering the GC. But by itself, though, it doesn't provide all the coverage, and so that's why we do combination treatment. And in all of this, there's always the anti-inflammatory. So I'm not selling any product. I'm not aligned to any company. So there may be Brufen added, or Cataflam, Voltaren, any one of those might be added to the drug line. And as Jamaicans, I can speak to Jamaicans, we tend to like to rub, to insert, even when you give them the oral and tell them it's systemic treatment and they're gonna be, it would be effective. Jamaicans like to apply. So they like to know that they have a cream or they have an insert that they can use. And so that can be applied, but really you're not doing anything different than if you had just done oral therapy. And then we move on to genital ulcer disease. And these are conditions that cause a break in the lining of the skin or mucous membrane. And really the most common organisms are either syphilis or herpes. Syphilis by itself is a bacteria, herpes is a virus. So the method of treatment are two opposite ends. One is antiviral, one would be bacterial. So syphilis, though, is very complicated. And there are four stages to the disease. So there's primary syphilis, there's secondary syphilis, there's latent syphilis, and tertiary syphilis. And again, as was stated before, it's an STI spread through sexual contact, and again by through mother to child. So when you talk about primary syphilis being first, that's what primary means. Primary school, not high school, not college, which is tertiary. So think along that line to think about syphilis. First time happening, it's the first time you're seeing something like this. And so there's a presence of a sore or at the site of the infection. And I try to make, because for me, a picture paints 1,000 words. If you can actually see what it is that we are, because some persons have never seen, I think I've seen one case of infectious syphilis where there's the active sore. However, it may be a single painless ulcer. Base is generally clean, edges firm, and you may have painless lymph nodes. And the incubation period is really within 9 to 90 days. Because after 90 days, it's not primary syphilis anymore. So they will tell you just last week or 2 weeks ago that I noticed the problem, etc., or whatever. But it has to have a history of within 9 to 90 days for us to say primary syphilis. And yes, there is the painless ulcer that is there. Then we move on to, so I'll deal with the management of syphilis, because depending on which one, the management differs slightly, just by duration. So I'll just do management of syphilis at the end. So secondary syphilis. So if we did not treat primary syphilis, because remember the symptom really is a painless ulcer, painless lymph node. So it may go unnoticed. And so because it is of a short time, 0 to 3 months, the person might not have realized that they had the sore, the ulcer there, especially if it happened inside, for example, the cervix. You're not gonna be seeing your cervix, so they probably would not realize that this is what is happening. And so it may progress to secondary syphilis. So after a while, after 90 days, a year time, I'm dark. So you might not see it on my skin like the skin here of the person, but you may see it in the middle of my hands or my palms, that There are wart-like lesions in their groin, patches inside the mouth, the palmar and or plantar rash, generalized lymphadenopathy, and symmetrical non-irritant skin rashes. And just looking on the trunk of this individual, you see what we're talking about. And it's called the great imitator because it could be that this looks like ant bite, it could be that it's scabies. So it's not a true picture of itself, it mimics what others look like. And then there's latent syphilis. So you did not get to catch it in a year, but many years after, you go to the doctor and doctor orders, you're going overseas and they're filing for you and you had to do a syphilis test. And the syphilis test is positive, but you can't recall having been treated for syphilis any at all. Nobody ever told you that you had syphilis. You never even had the secondary rash. So, or probably there was a rash, but you didn't even realize that it was, because you live in a community where there's, you do farming and you may have discoloration of the hands because of what you do. So you didn't even realize it was. So it's only recognized most times by a positive serology test. And if it doesn't get treated at latent, usually 10 to 30 years after the initial primary infection, the individual may be diagnosed with tertiary syphilis. And it tends to be identified, and I'm hoping that I'm not offending anybody in mental health, but in our mental health clients, our clients with mental illnesses, a lot of times you'll find that a lot of them are syphilis positive. And that is when, because they started behaving irrational, something different, and that they were taken to the doctor for this psychiatric evaluation, and the baseline labs were done and they are syphilis positive. So you may find that what I have noticed though for St. James, for the parish which I've worked in STI for before coming to the region, all of the mental health clinics, the clients had annual syphilis screening done, because we realized that a lot of them were being diagnosed in mental health clinic. And so it will affect just about any organ because of the length of time that, so it says it may affect the heart, the blood, the blood vessels, liver, bones, joints. There may be swelling, and it can actually lead to death. And the neurosyphilis, that's the one I spoke about just now. This is when it affects the brain and the nervous system, and it can actually affect the eye also. Because again, I said altered mental status, abnormal gait, difficulty coordinating muscle movement, numbness in the extremities, weakness, paralysis, problems with concentration, confusion, headaches, and seizure, vision loss or vision problems. This is when persons go into a doctor, and I'm gonna say a good doctor and a very sensible doctor thinking outside of the box will always think to do some baseline tests. So baseline hematology, yes, but baseline infections like syphilis and HIV, HPV, just baseline, because it doesn't hurt if you know. It's better to know and start treatment than not to know. And sometimes it's just simply baseline tests that these individuals do and are diagnosed with syphilis. So how do we diagnose syphilis? So if you find the person in the primary stage, the infectious stage, you may be able to see the chancre, the sore, that painless sore with a firm base, and you may identify the lymph glands, that they are swollen there, but they are non-tender. And then to confirm, you may end up doing some blood tests for the individual. So you may do non-treponemal test and or treponemal test. Remember, the very first thing that we had mentioned was the organism, the spirochete. So the non-treponemal tests are not definitive or specific to picking up the spirochete. But you know, sometimes you do some tests and it will give you a a preliminary positive test, and then you send for confirmation using a treponema. That's a specific test. And then if that test is also positive, and that confirms the presence of syphilis in the blood. For us here in Jamaica, we use both. So there is the SD Bioline test, it's specific, it's a treponemal test. But you may find that you go to some doctors and they use VDRL and or they use trust tests. Those are not specific. Let me see if I have a slide here. Right, so when you look at the non-treponemal tests, trust, the VDRL, and the RPR, I'm looking for my paper that I wrote down that what these mean before the end of the presentation. I should be able to tell you exactly the meaning. However, if you find that you have a non-treponemal test with any of these readings, 1 in 8 dilution or 1 in 4 dilution. So a 1 in 8 dilution and above, 1 in 16, 1 in 32, 1 in 64, 128, 256, 10, 60, 10, 12. Those are specific to syphilis. If it is a 1 in 4 and or lower, you might find a 1 in 2, or you might find NR, non-reactive. You would really, and if it's the first the patient is having this kind of a test, you would really need to do a treponemal specific test to confirm that this is definitely syphilis that the individual have, because a non-treponemal test might be also negative in primary syphilis because it might be an early infection. It really does measure the activity of the disease and is really used for post-treatment. So for example, the trust is what would give us the 1 in 8, the 1 in X. If you do a non-treponemal test, say at an outstation that doesn't have the SD Bioline test, they might find somebody with say 1 in 256. Definitely that person would have to treat for syphilis because it's above 1 in 4. And so what would happen is that 190 days after the last injection, they would repeat that test, and you should see it coming down to less than 4-fold. So if you started the patient at treatment at 1 in 256, you should see it down to 1 in 16. And then you repeat it again in another 3 months, and you should see it at least 1 in 4. If when you repeat it, it is at 1 in 512, it was 1 in 256, and now 1 in 2 in 512. What you would not repeat the treatment. What you would really do is to have the test repeated, but instead of 3 months time, you will repeat it in 1 month time. Because although it was higher than the last one, the first one, which was 256, and it is now 512, it is not 4 times the 256. So because it's just double, chances are when you did it, it was really early, and 256 was not even the truest reading. It might have been higher, but now you've repeated it. You're getting now, you've gone with treatment, and you're seeing 512. It could have been coming down from a higher number, but because we did it early, we only had seen at 256. However, if you gave treatment and it was 1 in 256 at the start, and you're now seeing it at 1 in 1012, 1012, then something is wrong. This patient is reinfected. You have to explore the partners, because sometimes we bring John Tom, and when we test John Tom is negative, because John Tom is the one who we live with and he's the one paying the fare. But there is the co-worker. We provide lunch in the daytime when we go to work. We didn't bring him. So John, you have to get a deeper, into the contact tracing. And this is where the contact investigators will come in, because they'll really have to dig deep to see where are the contacts for this person. Because if you started at 256 and now you're at 1012, definitely is a reinfection. And so we need to find out who else you are having sex with. And these are the specific tests, the treponema specific tests. As I said, in the government system, we have SD byline tests. I'm sure some, and the TPPA, treponema, pallidum, something another I say. I'll tell you before it ends. We have these tests in the government system in Jamaica. I know that some private labs still use VDRL. We don't really use VDRL. So we don't report using VDRL. We use SD byline tests, and we use the trust for monitoring. So how do we really manage syphilis? So there's primary syphilis, remember, secondary, latent, and tertiary. So depending on the stage of it, the drug is the same, it's just the duration that would differ. So primary syphilis and or secondary syphilis, it's really benzathine penicillin G that is given, and it's given 2.4 mega units as an injection, and it's done weekly. So 2 doses, one today, Thursday, and one next week, Thursday, 1 week apart for the 2 doses. However, if somebody came and they got it, one today, and they were afraid that it was so painful, they didn't come back next week, Thursday, but they came the following week, Thursday, and got the dose, that would have been fine. However, if they come back in a month time or 6 weeks time, definitely they're going to have to start the process all over. So they would have to repeat treatment as though they are brand new. However, if the individual is allergic to penicillin, these are the alternatives. They are not effective, but at least the person would have started treatment. Doxycycline or erythromycin or azithromycin as per the dose. For latent syphilis, so whether it's early latent or late latent, the same benzathine penicillin, same 2.4 mega units, but it's can be given for 3 weeks or 4 weeks, depending. Some clinicians go for the full 4, at least they're sure they are covering, but some 3 would have been adequately covered. So again, what is mother-to-child transmission? Yes, there's HIV, transmission of HIV, mother-to-child, but I haven't, the presentation for HIV, not in this one, I will open that one. But the HIV presentation would take us many moons, depending on who we're talking about, but management of the pregnant person living with HIV, I have covered it here in this presentation, so you will see this going forward. But I did not speak about HIV and the symptoms, etc., because HIV by itself is really asymptomatic, just probably flu-like symptoms. When the person progresses to AIDS, then they may have the skin rashes, the thin hair, the vomiting, the weight loss, etc., the lymphadenopathy, and other opportunistic infections. So speaking about HIV, really, HIV is just the presence of the virus in the blood, and how do you manage that? So I am not talking about AIDS today, I'm just mentioning HIV infection in pregnancy. So mother-to-child transmission is the sexually transmitted infections that are passed on from the mother to child, either during pregnancy, labor, delivery, and or during breastfeeding. How do we prevent mother-to-child transmission of STI, sexually transmitted infections? The fact is, get treated for STI as soon as it is identified. So you're a woman in the childbearing age and you do have an STI. You find out that you have a discharge. There's a break in the continuity of the skin, the vagina, there's a bump. It comes up every now and again and it goes down, it itches or it just burns or whatever. Get it treated. Reason being, the fact that you are being tested for an STI, you're at risk of pregnancy. And if you are at risk of pregnancy and have an STI, you can transmit same to your baby. There's something though about Jamaicans though, when we are pregnant. The only thing that we are concerned about within pregnancy is that we cannot get pregnant again. And so a woman who is pregnant automatically stops using condoms. And because she cannot get pregnant while being pregnant, unlike a dog, who the dog may be able to be impregnated by 3 different bulls at the same time. A lot of us don't know that. But during the mating season, 1 dog can get pregnant for 3 bulls. But so as women, we don't think outside of pregnancy with once you become pregnant. But then that's the doorway for a lot of our women. A lot of our women are diagnosed with HIV in pregnancy and a lot in the late pregnancy. Their first blood test would have started off HIV negative, baseline HIV negative. And then somewhere in the 2nd trimester, there's an HIV positive result. How? Get tested for HIV. If you don't have HIV, use the condom correctly and consistently to prevent STIs. And that's the message that we should take home to not just ourselves, but the patients whom we serve, and encourage them to get their partner tested for HIV, because your HIV negative status does not define your partner's status. Because as I always say to my patients, you're not always where your partner is. And so people work with people, and over time I'm working here and I have 3 male staff here with me. I'm just using that by number though. I have so many males with me. And I get to like this particular one. We work late in the evenings. I'm going home to my husband. He's going home to his wife. But in daytime, we have that kind of relationship. Anything can happen, but this is how we are. So STIs and HIV. So I would have given the backdrop for STI and I'm looking now at HIV while we specifically delve on gonorrhea and syphilis. As I said before, 2 don't walk unless they agree. If you're going to treat somebody for gonorrhea, chances are that person is at risk for HIV because you must have had sex without a condom. The prevalence of STIs, of HIV amongst STI clinic attendees was 2.8% in females and 5.4% in males in 2018. And if I were to use just Western regions data, where for the January to March period of this year, 2022, only 49% of our STI clients were tested for HIV because we don't have STI clinics in all of our health centers. So the few patients that were tested that got treated for HIV, 7.9% of them were HIV positive diagnosed. And that's high because we only tested less than 50% of our the attendees, and we had a 7.8% prevalence. So as I said, 2 don't walk unless they agree. The presence of an STI increases the risk of HIV transmission 3 to 5-fold because there's a break in the continuity of the skin. And we know HIV being bloodborne. Once there's a break in the skin, there's easy transmission of HIV. A previous STI is a common risk factor. Or a lot of our PLHIV will say, yes, they were treated for an STI. So most of the STI clients that we have will tell you, yes, I was treated for an STI, or it was when I was getting treated for an STI that I was told that I have HIV. Untreated STI facilitates HIV infection, HIV reinfection, HIV transmission, and HIV disease progression. What do I mean? So some persons also, we have that where you have partners, persons are diagnosed with HIV and are taking ARVs. And I have HIV, my partner has HIV, or I'm having sex with somebody else outside. I'm not thinking that I can get HIV. There are different strains to HIV. I don't know how many of us know that we have HIV 1, we have HIV 2, we have HIV slow progressing, and HIV affects everybody. Some persons, the minute they get HIV, they are so sick and they're weak and they start losing weight and they get to AIDS flying based on their immune system. Another person has HIV and is so strong and moving around and you don't know. So I say to people, HIV affects everybody differently. And so, yes, I may get a different strain of HIV, and I always tell them 2.1 a murder. So if I have HIV type 1, and we don't test in this, in our country, the types, because it doesn't really matter. You have HIV, you're going to be needing treatment. But what we know that it is assumed that the persons with type 1 are the slow progressors. And so even if they're not taking medication for years, it may take them a long while before they start having symptoms versus those with the type 2. But this side of the globe, we don't actually test type 1 or 2, we just treat. And as we said, untreated STI facilitate the transmission of HIV in body fluids, yes. The disease progression, it's going to break you down faster. So that's just explaining that. So what are the complications though of untreated STIs in relation to mother-to-child transmission? When we think of syphilis, if it is not treated properly, untreated, none at all, not treated, or treated but inadequately treated, there is the risk of congenital syphilis. Untreated or inadequately treated gonorrhea, there is the risk of ophthalmia neonatorum and also chlamydia. So the causative organism for ophthalmia neonatorum is always either gonorrhea and or chlamydia. For HIV, it's definitely pediatric HIV. And also under syphilis, we may have the woman has stillbirth, woman has infertility. And just by way of information, because sometimes we are not all as nurse practitioners on the call, and we're not all treating patients, but by way of information, because you will have some persons that they are having, every pregnancy it's a stillbirth, every pregnancy it's a stillbirth. They just lose the baby and they don't know. Because not every clinician is holistic in their approach to management of the antenatal woman. And so, because I've had cases where they've had 3 stillbirths and until they came into primary care and decided to come to the health center and where the midwife asked, request the tests and or have the blood test done and they find that they're SD positive. For a lot of them, especially a lot of these women, and they are 1 in church and they are 2 married. How could this happen? And I've been losing, and they are now putting the dots together. Oh, so probably it could have been. And the thing about us as Jamaicans, and I'm apologizing for those who are in foreign, the persons overseas, speaking to Jamaican, because that's the where I have worked and have gotten most of my information from. Once persons identify with an STI, that they have an STI, there's always the need to try to find out who they got it from. And I always try to reassure the clients to say, okay, you're not going to always know who it is. It's not always going to be possible because, for example, remember when I said for gonorrhea, the woman may have the disease and doesn't know, and until the man starts experiencing symptoms, then, you know, he finds out and sends her to test, she might have it. And also HIV, the woman might be a healthy carrier, doesn't have HIV symptoms, and the man starts feeling sick, whatever, has his test done and realizes he has HIV. He's sure that he's having sex with Donita only, and only then Donita goes to get tested, and Donita finds out that she is also HIV positive. So, but persons always try to start playback. Who was the last person? And sometimes it's not the last person. But you know, you always try to have the sit down with them to say, all right, let us explore your risk. All right, when did you start having sex? 15 years ago, how many persons you had sex with? More than 20 persons. And when you start to play it back, so how do you know that you know who and wherever? And I always draw with my patients. So I do stick man, and I always draw you as one, and I draw the partner. And I said, and I always create imaginary circles. So yes, I am with you as the partner. That's what you know of. But guess what? I have 3 more. And those 3, I draw partners to them. And sometimes I draw 2 partners to each of those 3. So that means I, the central person, is having sex with these 3 who has 2 partners each. So I am having sex with 6 and 3, 9 persons. And you play it back to them. So I said to them, it's very hard to find out where it's coming from because you don't know who is in your circle. And so sometimes I use that. And even when I'm doing training with my student nurse practitioners, student nurses, SHOs, I always use that with them also so that they can think, if I'm in the circle and you're saying that all of these persons I might be having sex with, I said yes. So if you don't use condom with this person, you cannot block all of what is coming in from all the way over here. Sometimes that's when someone then really wake up to the call to say, okay, yes, this is true. But getting back to the point, complications of untreated STIs, we see the different types. I thought I had done this, so that means my slide jumped. All right, so let me just go back there. So there's one point I should have said on this slide, and I apologize for the one before. The last point on this, as I said, the duration of the treatment is the same benzathine penicillin, but the duration changes depending on what you're treating. But if you have a patient that is allergic to penicillin, they tend to use the alternative treatment. But as we said, it's inadequate and it's ineffective. What in some countries and in some areas, what they do is admit the patient, and then the infection control specialist manages the patient. So they actually do a kind of a desensitization test with the client and have the client treated. So they may give what we call like test dose to under specific conditions. So you'd have your tray, your emergency trays and everything in place. And this is done over a period of time until the patient gets the actual dose of the medication. If it is that the benefits outweighs the risks that are involved, and all of those are weighed. So to prevent the transmission of syphilis to the unborn child, once a woman is diagnosed with syphilis in pregnancy, and I'm sure it's looking like I have something missing here. Once a woman is diagnosed with syphilis in pregnancy and gets treatment, remember I mentioned that we have the test that we use to continue for monitoring the trust, the non-specific, that one would tell us reactive 1 in 4 or 1 in whatever. This is done on a monthly basis until the woman delivers to see if it's increasing, if it remains the same, and or it is reducing. And also, if a woman was diagnosed with syphilis, whether before pregnancy or during this pregnancy, if the woman becomes pregnant again, we call that an old case, she gets a one-off start dose of penicillin. And also, we continue to repeat her trust during the pregnancy until she delivers. I'm not sure if we can see this algorithm here. I tried my utmost best to put it across as big as possible, but it's looking at antenatal screening of our women, and if we diagnose one with pregnancy, how do we manage? So we have the antenatal screening done. As I said, we do SD bioline test. It's a treponemal test, and it is reactive. Yes, that means it's a plus. We also do the trust to find out how high in the system it is. And so when we do the trust, we see that it is reactive, less than 4 or greater than 4. Remember that I said anything above 4 must be treated as infectious syphilis at the time. And if it is less than 4, we may treat and we do the monitoring on a monthly basis. Greater than 4, we treat with the 2 dose or the 3 dose, depending on the history that we have. If we do the test and it is not reactive, and when you ask the questions, though, the woman, the risk factors are low. I see here where it is repeated at 28 weeks, but we repeat in 4 months. And we also give the 1 dose off, because it is better to give a woman the penicillin and treat in the event that she's positive, than to not treat her because we're thinking that it was non-reactive. So although she had a SD bioline positive, the trust then was non-reactive. Non-reactive, it means that there's no active infection. But if this woman would have said that she was treated in the past, so it's an old infection, chances are it's not new. It's because this is still picking up syphilis in the system. So we would just treat on 1 dose. But if the woman said she was never ever diagnosed with syphilis before, but you have a non-reactive response, you will have to treat as for syphilis, because it could be very well a new infection, a very new infection. So there's not enough antibodies to pick up and to do a response. And so you will treat as per normal, the weekly for 2 weeks or the weekly for 3 weeks, depending on what we're thinking. And we monitor the trust on a monthly basis until delivery. And so congenital syphilis is where we are. And when we speak of congenital syphilis, we speak of the child being born with syphilis. But how do we make that diagnosis? So the diagnosis is made, one, I'm going to use the second one first, by case definition, where if the child is born to a mother with untreated or inadequately treated syphilis. So remember that I said the mode of treatment is really the benzathine penicillin. But if a woman got benzathine penicillin less than 30 days before delivery, she got penicillin 2 weeks before delivery, she's inadequately treated, because she would have had to get it for more than 30 days before delivery. So she would be classified as inadequately treated. So that baby would be classified as a case of congenital syphilis. Likewise, if she got erythromycin, that would be a case classified as congenital syphilis, just by case definition, meeting that criteria. Remember that we said that, yes, it can treat, but it would not be adequate treatment. The other being that the child shows these signs and symptoms of the disease. So there might be hepatomegaly, skin rash, pseudoparalysis, anemia, edema, and the Huntington's disease. If the infant is asymptomatic but has a trust, a non-treponemal test titer 4-fold more than the mother. So the mother at delivery or before delivery, the last month of delivery, had a reactive 1 in 4. However, the baby was born with a reactive 1 in 16. Definitely, this is a case of congenital syphilis. So how do we treat a baby with congenital syphilis? We look at aqueous crystalline penicillin, or Crispin, and it is, as stated on the sheet, 50,000 units per kilogram per dose, IV every 8 to 12 hours. A maximum of between 100 to 150,000 units daily for 10 days. Or procaine penicillin, 50,000 units iron stat, and then daily for 10 to 14 days. So one is 3 times a day or 2 times a day for the same 10 to 14 days, and the other is just once daily for 10 to 14 days. Normally, because if the mother was treated with emycin or treated less than the 30 days before delivery with penicillin G, that baby has to be admitted, and the baby is treated as per this regime here for congenital syphilis. Let me see what this is. I'm not. Okay, moving on to the next condition. So remember we had said congenital syphilis. The next one we had discussed or mentioned was ophthalmia neonatorum. Ophthalmia neonatorum really is occurs in an infant with a mother who had untreated or inadequately treated gonorrhea or chlamydia trachomatis. So the baby at birth may show mucopurulent or just a purulent discharge from the eyes, and it happens between birth and 1 month. There's also redness or swelling of the conjunctiva, and most times, as is stated, that the organism is gonorrhea, Neisseria gonorrhea, and it should be treated as a medical emergency because once it is a class 1 notification, and for sure that most of us would have either been rotated through the maternal ward, would note that the babies get tetracycline eye drops at birth. It's really prophylaxis to prevent them from getting the infection. But in the event that after the child is sent home within 2 weeks to a month, or 6 days to a month, we realize that a child has the symptoms that were discussed before, the redness and swelling of the eyes, the mucopurulent discharge. The infant is brought back to the facility, health center, local health center, and or the hospital. And doctor, because as I said, it is a medical emergency because one of the complications is blindness. A swab and eye swab is done, and the infant is treated with ceftriaxone 50 milligram IM stat plus the tetracycline eye ointment. Because the most causative organism is gonorrhea, the tetracycline also works well for the gonorrhea. However, if we're thinking chlamydia as a causative agent, then we would treat with erythromycin suspension, 4 doses for 3 weeks, 4 doses per day for 3 weeks, but you would not use any eye ointment. A swab would be taken from the baby's eye, sent for testing for confirmation. And so sometimes the infant might be sent home after the treatment with the tetracycline eye ointment. But after the swab results come back, they might be told you do not have to use the swab because X or Y. And as I said, complications of the congenital syphilis are failure to thrive, skin rash, nerve damage. Ophthalmia neonatorum would be corneal scarring and or blindness. So I would encourage us that when we have our antenatal mothers, that we encourage them to have their the blood test done to rule out syphilis, because we see the damages that can happen. So before we even get to congenital syphilis, the woman is at risk of having a stillbirth. So that's one of the complications too of syphilis in pregnancy. But if she should take the infant to term, the chance of congenital syphilis resulting in failure to thrive can happen. If the woman has gonorrhea, discharge untreated, not treated, or inadequately treated, there's a risk of ophthalmia neonatorum, and so the baby can have blindness and or corneal scarring, which eventually causes blindness. So really, how do we prevent the transmission now of HIV? Remember I said, once the woman has her antenatal test done and she's diagnosed with HIV, then we would treat HIV. So we're not thinking AIDS now at this time. So there's no opportunistic infection, there's no skin rash, there's nothing. So a woman diagnosed with HIV, and as a matter of fact, not just a woman, any client diagnosed with HIV now in Jamaica, It started off on tenofovir, lamivudine, dolutegravir as first line. It is a drug, it is a one tablet with 3 combined drugs in the one tablet, and it is taken once per day. It is effective if taken the same time on a daily basis. And with HIV, there's a little bit more frequent management and monitoring that goes with it. There's a monitoring of the CD4, that's the immune response. And there's also monitoring of your HB, etc. And there's frequent checks for other organs because HIV can affect just about any organ. Every woman of childbearing age should get tested for HIV. If diagnosed with HIV, they should start antiretroviral therapy for both their health and their baby's sake, just in order to prevent transmitting of the HIV to the baby and to their partner. Again, if they don't have HIV, then we ask that they repeat the HIV test at the 3rd trimester as per normal too, because as I said in the initial, they may not have HIV in the 1st trimester, but may end up acquiring HIV some sections along the pregnancy. And as always, have your partner tested. Your HIV status is not your partner's HIV status. So we have 2 women diagnosed with HIV, or we're going to be talking about 2 women diagnosed with HIV. The woman with HIV, however, she knew that she had HIV and she's now pregnant. So this woman is a person living with HIV. So PLHIV is person living with HIV. She was previously diagnosed and she was always on her antiretroviral therapy. How do we manage this woman in the antenatal period? This patient, she will continue her antiretroviral therapy. She will continue her regular appointments at the doctor, and we seek to reinforce adherence to ensure maximal viral suppression. Her viral load test is done every 3 months because you want to know what her viral load levels are. Remember, the viral load really tells us how much of the virus is in the system. The higher the viral load, the greater the risk of transmission. The lower the viral load, the lower the risk of transmission, both to her sexual partner and her unborn child. You might have heard me mention viral load and CD4. So the CD4 are the soldiers that protect the body. Without HIV, all of us have CD4 counts. When you are infected with HIV, the CD4 counts are the persons that the virus attacks. So he attacks the security guards of your body. He tries to get to the lieutenant and the army commander, the commissioner of police. Those are the persons that we call the CD4 count. And so because the CD4 counts, they are always on the watch. They are at every aspect. They are at the door, they're at the window, they're at the sides, they're looking, they're trying to protect you from all of these wicked viruses that have trapped their way in or trying to creep in. And so what happens is that if they, without the ARVs, your policemen and your soldiers will fight, but they will get to a time when they by themselves are not able to manage. And the virus, though, unlike the body that will get tired, it does not get tired. It keeps replicating and replicating and replicating. And every time it has a new set of children, they are stronger. And so they will eventually overthrow those policemen. And so what happens when those policemen fall asleep and or get injured on the job, and those children know of the virus multiplies, they bring the system down, and eventually a person progresses from just having HIV infection to AIDS. When the individual on the other side takes the antiretroviral therapy, Not only does the policeman have their, what's the thing that they walk with, the stick, but they also have their gun. They also have additional ammunition, and they have their um, bulletproof vest, and they have the helmet, and they have the eye shield, and they have everything. Because they are so protected, the viruses take a longer time to get to them and to inflict them. As a matter of fact, those viruses, after a while, no matter how they're replicating, they are never able to destroy the person because of the protection that the ARVs continue to give them. And so we monitor that during the course of the pregnancy. We try to see how much of the virus is in the system. And we also see how your policemen are looking. If the viruses are high, chances are the policemen are getting lower, they are dying. But most times, if it is at the policemen are at a certain level, they tend to keep the virus down. And so if the viral load is greater than 1,000 copies per mil in the system, we have to have a delivery plan. So as a matter of fact, once the woman is pregnant and has HIV, a delivery plan has to be sat down with the gynae team and the PMTCT nurse team. The whole antenatal team has to sit down and discuss what is the way forward for Donita, who has HIV and is pregnant. So everybody knows if her viral load is over 1,000, she has to deliver by C-section. If it is less than 1,000, then we are going to give her the chance of normal delivery. And so this woman will always have to be told, they have to have the preparation for the units of blood, etc., preparing for C-section delivery based on their viral load levels. And as I said, it is done every 3 months, as in every trimester, and depending on the levels. Because remember now that the antenatal visit is much more frequent nearing the end of delivery. So we would have started out monthly, then we got to 2 weekly, then we got to weekly. And so even if a woman is due to have baby and her viral load result is not back, this is one client that we will have to call the lab to say what is the result of the viral load, because the delivery plan must be executed. So that was Donita, who we know that she was an HIV positive woman and she is on her ARVs. But also there's the Donita who was just diagnosed in her second trimester or in the third trimester or probably the first trimester. She was just diagnosed during this pregnancy. She will have to start ARVs as soon as possible. Again, the ARVs are safe in pregnancy. So there's no giving up this type versus that type. The first line therapy that we have now, the dolutegravir, is what is given, and it is safe in pregnancy. And again, we ensure to and encourage the woman to take the medication the very same time every day. And again, the same delivery schedule is followed, where the plan is, and we continue monitoring until the management of the, let's see what is up here. I'm sorry, let me see what my head is. All right, so the management of the patient, though, is different depending. So the one who was known and was always diagnosed, the management is a little bit different versus the one who was newly diagnosed. The one who was newly diagnosed, we would classify that woman as a high-risk mother. Also, you might have a patient that is known HIV positive on ARVs, but is also classified as high risk. Reason being, she's poorly adherent to her ARVs before the pregnancy, and also during the pregnancy. She's not taking it, none at all. So there's a management schedule for this high-risk client versus another patient who we classify as high risk is the person who she was diagnosed during the pregnancy. Because at the point of diagnosis, you are very, very infectious because the viral load tends to be very high. So a new HIV diagnosis in a pregnant woman or a breastfeeding woman who was previously HIV negative makes her high risk. if it is at delivery, sometimes when these women come in at delivery and we're doing the bedside test because they did not have any antenatal care, that we're finding out that they are HIV positive, that's another woman who is high risk. The management of that child is going to be different. And so also a woman who we diagnosed her in pregnancy, but she started taking ARVs like within less than 30 days or 4 weeks to delivery. And let me see what this one is. The woman whose viral load is greater than 1,000 even at the term at delivery. So these are all the high-risk women that we have. So the child for this mother is managed differently from the woman who is controlled and her viral load is far less. So just bear in mind that the woman who was newly diagnosed in pregnancy, the woman who was diagnosed in breastfeeding, the woman who started ARVs just 4 weeks and delivered, and the woman whose viral load was very, very high. How do we manage this child? So at delivery, the obstetrician wants to ensure that there is limited contact time with the maternal blood. So they are in and they are out quickly, and the infant is decontaminated, as in bathed, etc., cleaned up as quickly as possible. So they ensure decontamination of the newborn to limit exposure to potentially infectious birth products and secretions. Breastfeeding is not recommended in any HIV positive women. And I will tell you that there are some countries that if the woman is controlled on her ARVs and wants to breastfeed, it is allowed. However, as a country in Jamaica, we have not, well, in the public sector, I can speak to public sector, because, you know, in private it may happen, I don't, and I cannot speak to private. But we do not encourage a woman who is HIV positive to breastfeed. We know that there are some, I'm gonna say, some areas where persons, they may leave hospital knowing that they are not to breastfeed, but because there is influence of a grandmother or the relatives around, so why you can't breastfeed, or, you know, what is it? What kind of medication you couldn't, I'm sorry for the language, but what kind of medication could you be taking why you can't breastfeed? Because a lot of them tell them that because they're on antibiotics, you know, they can't take the ARVs, or because they got cut, they can't breastfeed, sorry. So those are some of the things. So some people will tend to actually breastfeed the child because they are pressured from the so-called grandparents around them. But how do we manage this child? So both infants, whether high or low, are given, it's dual prophylaxis, as in 2 drugs. But what is different is the duration of. So the high-risk infant, remember what were the features or the infants that were considered high-risk? Those born to those mothers whose viral load was high before. They would get zidovudine 4 milligram per kilogram every 12 hours. So that's twice a day for 6 weeks. And also the nevirapine 2 milligram per kilogram once daily for 6 weeks. And the child may be admitted if resources are available. Reason being, if you think that the mother was not adherent herself during pregnancy, chances are this baby is not going to get the medication within the stipulated time. So if the facility can afford to admit the child, because you know spacing an issue, spacing may be an issue. So the child should be admitted. We recommend that the child is admitted. Also, if you think that the mother may breastfeed the baby, we admit the child so that at least for the first 6 weeks of the baby's life, the mother does not breastfeed. The mother visits and the visit is supervised. So by the end of the 6 weeks, the breast milk, remember now, the more the baby sucks, the more milk is produced. So if the baby is not sucking, then the milk would have, she would have some amount of pain, yes, but then the milk would start drying up. So because breastfeeding would not have been established. So we do admission based on the availability of the resources or the conditions that we see leading up to delivery. The low risk child, or the low risk mother and child. And so who is the low risk mother? So this is the woman who had, Donita, who had HIV many years ago and has been taking her ARVs and was virally suppressed even up to the time of delivery. And she's consistent on her ARVs. As a matter of fact, it's not her first pregnancy. She's been doing well, and she has been taking her ARVs. If you notice that it's the same zidovudine 4 milligram per kilogram dose that she gets twice daily for the 6 weeks. However, the nevirapine is just a stat dose. And again, as I said, as a country, we do not establish breastfeeding, but that's still a no-no for a pregnant PLHIV, person living with HIV. So how do we actually diagnose HIV in the infant though? Again, the management, as I said, is different, high risk versus low risk. So just like how we would do the ARVs for a period of time, diagnosing is different. So the infant that is born to a low risk mother, and I'm just saying that so that we remember. I know there's a lot of information that we're giving, but I'm hoping that at the end of the presentation, you'll find it useful. The infant that was born to a low risk mother would have at least 2 DNA PCR tests. And plus at 18 months, they have a test. But the PCR tests are done at 6 weeks and at 4 months of age. So at 6 weeks and at 4 months of age, that's the 2 DNA PCR tests and the rapid test at 18 months. However, the infant that is born to a high-risk mother, or the infant that is considered as high risk, that infant would have to have 3 of the DNA PCR tests done at 2 weeks of birth, at the 6 weeks, and repeat at the 4 months. Because if it is that at 2 weeks, the baby has a positive PCR test, while we will have to wait for confirmation in 6 weeks' time, we would be able to start on opportunistic infection prophylaxis. Because remember now that this baby's immune system, she would not have a lot of police guarding her doors. And so some of her windows have already been exposed because the virus is already in her system at 2 weeks old. She will not be able to fight these monsters. So we would have to give her opportunistic infection prophylaxis. So that's medication to prevent other infections, and mainly most times it's to prevent lung infections. So they would get what we call Bactrim, cotrimoxazole at the dose per age. And this is given daily until they have the 6 weeks test. If at 6 weeks it is repeated and it is negative, remember that you can have spilling of the mother's blood into the baby. So yes, you may have I'm gonna use the word false positive, but you may have a positive at 2 weeks, but when it's repeated at 6 weeks, it's negative. And when it's repeated at 4 months, it's negative. So this mother, you want to ensure that this baby is admitted, this baby gets their medication. And so if at 2 weeks, as I said, it's positive, you ensure that you start Bactrim, and then you continue the 6 weeks test. If at 6 weeks it's confirmed, some facilities still do the 4 months test, but really it's just 2 PCR tests that you want to have positive. So if your second one is positive, you will just continue on the management, diagnose HIV positive, and they continue as per an infected child. Just to say that for the infants who are born to mothers who are HIV positive, because they are not allowed to breastfeed, the government of Jamaica provides formula for that infant up to 12 months of age. So up to age 12 months, the baby gets formula, and they pick up on a monthly basis. The baby is supposed to be taken to the clinic at the time when the mother is going to pick up. because the nutritionist will get the opportunity, the privilege to do the nutritional assessment for the baby. Because yes, the baby may go to child health clinic and all of these things, and height and weight, etc., is done. But if the child is infected with HIV, there may be stunting of growth or failure to thrive. And so a proper assessment of the baby can be done. A lot of times, though, the mothers tend to want to go without the formula because to pick up the formula without the baby. But what we have implemented nationally, and I can only speak for Western, although it's nationally, that the mothers are only given like 1 tin of feed and told to come back with the baby to pick up the other 5 tins, because they generally give them at least 6 tins per visit. So I'm not gonna say per month. I'm not sure how often, but I guess there's a pattern that they use. And so if the mother keeps coming without the baby, the mother is not going to get more than 1 tin. And she's told to bring the baby so that the assessment can be done. But yes, everybody gets that until age 12 months. However, we know in our system that we have some mothers who have social issues, and they might not be able to work before pregnancy and no pregnancy. And so even after 12 months, they may need additional assistance. Although at age 12 months, you want that baby to be eating from the family pot. If there is no family pot for mommy, there's not going to be family pot for baby. So we still give some formula for those baby. Not, I'm gonna say undocumented. It is monitored how much we give really, but we are really monitoring the ones that are 0 to 12 months that we do give the formula. And so we want to have, as a country, be validated for elimination of mother-to-child transmission. So where are we as a country as it speaks to elimination of mother-to-child transmission? This is a program that the government of Jamaica would have signed up to in the Millennium Developmental Goals for 2030. And we are looking at where are we now? And I'm not sure how many persons on the call knows what I'm talking about. And what do I mean when I say to be validated for EMTCT? What does that mean? So really, the term validation, and this is, if you go to WHO website or PAHO's website, you'll see all of what I'm speaking to in relation to validation. It's used to confirm that a country has successfully achieved the indicators to eliminate mother-to-child transmission of HIV. So it's a method of controlling HIV, reducing HIV infections amongst the population if we can have children born without HIV and syphilis. And it is within a specific time, and we also must have some strong monitoring system to maintain the gains that we have gotten. Strong health system implies that the country will maintain ongoing routine, effective program interventions, and quality surveillance to monitor the elimination of HIV and syphilis. So it's not just having no more babies born to HIV mothers being infected, but also maintaining that over a period of time, it does not happen. So what is it that we have been doing? Where are we with it? So the indicators that this spoke to, remember it spoke to achieve the indicators. There are 2 sets of indicators, the impact indicator and the process indicators. So for HIV, the impact, so there are really 3 impact indicators, 2 for HIV and 1 for syphilis. And the country must achieve these 3 indicators for 2 consecutive years. So for HIV, less than 50 new HIV infections per 100,000 live births should happen, and a transmission rate of either, well, for us, we are not looking at the less than 5% because we are not of a breastfeeding population. So what we're looking at is less than 2% population prevalence in a non-breastfeeding population for which we are. So we should have less than 50 babies born with HIV, infected with HIV, and we should have less than 2% of them because we are a non-breastfeeding country. And for syphilis, the same, less than 50 cases of congenital syphilis per 100,000 live births. And I'll tell you that for 2020, we had 7 cases as a country, and for 2021, we had 4 cases as a country. So we're trending down for syphilis, but for HIV, we did not have 50 new births. However, I'll show you what the percentage was like. But what happened was that we have to maintain this for 2 consecutive years. We've never been at 50 new HIV and or syphilis cases. However, we were at over 2% in our prevalence when you look at it. And for the process indicators, actually, I have 3, there are really 5, but I have merged them. So we should have 95% or more of our pregnant women receiving antenatal care visit, at least one antenatal care. And this is one of the double ones. 95% of our pregnant women should be screened for HIV, and 95% of our pregnant women should be screened for syphilis. Also, another double one is 95% of our pregnant women who are diagnosed with HIV should be treated, and the same for those diagnosed with syphilis, they should be treated. So everything about the process indicators is 95%. It is the women that are diagnosed should be treated, whether for HIV or syphilis, but all our antenatal mothers should have antenatal care or antenatal testing. So where are we with this? So when do we apply? As I had stated before, that we have to meet both the impact targets for 1 year and the process targets for 2 consecutive years. I have one here for the impact targets because when you go to WHO site, it speaks to 2 years for both. But when I asked my program coordinator, what was the difference or whatever, they were, because we were so very near to it at one point, she said that it was revised or whatever, but I have not seen the actual document. So I have used the presentation coming out of the Ministry of Health HIV program as per the impact targets, that it is for 1 year, but the process targets must be for 2 years. So where are we as a country? And apologies for those persons who are non-Jamaican, but I'm presenting. So for 2020, 2021, and where we are year to date. So in 2020, when you look at the impact indicators, as I said, remember that because we are a non-breastfeeding country, we should be less than 2%. And for the cases of syphilis and HIV, we should be less than 50 cases per 100,000. So if you notice that we would have been less than 50 with the HIV infection and the syphilis infection. However, for the prevalence rate, we were over 2%. So we were at 2.04%. So even if we had gotten it in 2019, because this was over 2%, we have to start all over again. So for 2021, however, we are using that now as our baseline because for last year, we had only 4 cases of HIV, and we had 7 cases of congenital syphilis. And the 4 cases of HIV made us have a 1% prevalence rate. So using 2021 as the baseline, so we could say this is our year 1. We have 1 more year to achieve this and or less. And if we do this, then come 2023, we can then apply for that is hoping that the process indicators have the 95% in all of the 5 indicators. So when you look at the impact indicators for where we are now as of, this is up to, I think this is February data. I didn't have all of the sites for March. So I'm looking at where we are for January and February of 2022. We have not diagnosed any baby so far with HIV. And so it's at zero, but we've so far had 2 cases of congenital syphilis. And I will tell you that these are cases as per the case definition. Mothers treated, one treated less than 30 days prior to delivery, and the other was treated with erythromycin, which makes it inadequately treated. All right, so when we look at our process indicators, I am wondering if I did not have my process indicators for, let me just look at something. Okay, so obviously, but what I'll tell you for 2021, I thought I had it here to do the same comparison. We were not at, for the process indicators, we were very low. So remember that all of them should be 95%, the 5 indicators. Probably I got excited when I saw that year to date, we are above 95% with all of the indicators. But for 2021 though, we were not at the 95%. One of them we were at 83%, 91%, 88%. We were not at the 99%, so 95%. And so we have the process indicators now, the impact indicators now we are at the level. And for year to date now, we are at the 95%. So as I said, we have to have these repeating for next year to say, okay, yes, we are at that point where we can we can apply for validation. So right now we have none of our women diagnosed with, we have all of our women who have been seen in our spaces accessing at least 98% of them having antenatal care. We have 95% of them testing for HIV, and 52 of the 54 women who tested for syphilis, that is, 52 of the 54 women who have tested positive to syphilis have received adequate treatment. And when you look at HIV, we have 44 of the 45 women starting antiretroviral therapy. And just so you know and is aware that this includes women who were previously diagnosed. So it does not mean that 45 women were diagnosed between January and February with HIV. Majority of the times we have persons who are known. Because the data didn't ask for, I am unable to give you an idea of how many of these are newly diagnosed infections. It might be worth hearing, but of these 45, majority of these are repeat pregnancies in women who are already HIV positive. And so we see that 44 of the 45 women had started ARV to reduce mother-to-child transmission of HIV. And so what's the elimination history about? It was launched in 2010, and it's a regional initiative in the Caribbean, Latin America and the Caribbean. As I said, it is coordinated by PAHO and UNICEF. So it started in 2010, and we have been trying since then, but we have had turbulent waters. And in 2015, Cuba was the first Caribbean country to receive validation. In 2017, another 6 countries got validated. So that's Antigua and Barbuda, Bermuda, Cayman Islands, Montserrat and St. Kitts and St. Kitts and Nevis, they both got validation. And in 20, okay, so and also what we've seen is that as a result of this mother-to-child transmission elimination process, new HIV infections amongst children had reduced significantly by more than 40% amongst children between 2010 and 2019. The percentage has reduced significantly. And congenital syphilis cases remain at least at 9 cases per 100,000. So we are not getting anywhere near the 50 per 100,000. And just to say, we can't ask for validation for syphilis without HIV. They both go together. And in 2021, May last year, Dominica received validation. So in total, in the Caribbean and Latin America, or Latin America and the Caribbean, we have 8 countries that have so far been validated for the elimination of mother-to-child transmission of both HIV and syphilis. And as you see, I stated them before, it's Cuba, Dominica being the last one to be validated. And Maria Percival said in 2017 that the elimination of mother-to-child transmission of HIV and syphilis, it's not just a dream, it's an achievable goal. How can we help though is to ensure that all our women receive antenatal care. All of our women in their antenatal profile have a HIV and syphilis test. And all of our women, if diagnosed with HIV and or syphilis, they are adequately treated for the conditions and monitored and the baby managed. And so I thank you. But just before I go, I just know that I would have looked at, I didn't do these in the presentation, but I'm going to share the presentation so you'll see there were other STIs, although except for chlamydia, which might cause ophthalmia neonatorum, they may not cause transmission from mother to child, but they are in the presentation that you can look at, and for just by way of information, you may be able to identify what they look like. So chlamydia is a bacterial infection. Again, it's an imitator. It mimics gonorrhea. Most times persons don't know that they have the issue. The discharge is nearing the same. The treatment, as I said, would have been the syndromic treatment covering all 3. And unlike gonorrhea, which you may need to do a high vaginal swab to, this one is also done, but this is a bit expensive, but it is done in private lab, and it's a urine test that is done. And again, as I said, the treatment is azithromycin, doxycycline, and the treatment is there, including anti-inflammatory. But I don't know that I needed to speak to it, but it is here. It will be in the presentation unless persons have questions in relation to it. I think I don't know, but I think I am finished. So if you have any questions at this time, I'll take them. Thank you.
Thank you so much. Round of applause, round of applause. That was quite informative. Very, very good. So there is a question that was in the chat, and it was, were you able to determine how many of the 7% were previously diagnosed with HIV? And I think you kind of answered that in one of your later slides, that it was repeat pregnancies in one of the statistics you put up.
Yes.
So specifically to the 7%, can you speak to that?
With 7%, I can't recall speaking to a 7%. We had 7 cases of congenital syphilis in 2021, but not a 7%. So if you look at this slide, it was 7 cases of congenital syphilis.
Okay. So my question that I have is, the VDRL not a good test for testing for syphilis? Because I mean, even here in the States, that's what they use.
Because it is not a treponema specific test. But as I said, it's not just, so the VDRL will be reactive. So it's a preliminary positive test. Most times after they would do a treponema specific test, for example, the trust, to give you an idea of the reactivity of the infection in the system. So I'm hoping that they are doing two. So you may have VDRL reactive, and then you have trust reactive 1 in 8, 1 in 16, 1 in whatever it is. So you will have an idea of that.
So as a primary test for detecting syphilis, do you believe the VDRL is still a valid primary test?
It is valid. It is valid because it will give you a preliminary positive or a negative result. However, it's not specific because you may have somebody whose VDRL is negative, but when they do a syphilis specific test, the SD bioline, you have an SD, and so it may give the person some false sense of hope, because one of the cases that we had that was diagnosed late, this is somebody who was VDRL negative, but came to our system for delivery, and the midwife at the facility said, well, we do not use VDRL, and she did the SD, the bioline, and it was positive. So it is what is used in those spaces, and I cannot attest to say yeah or nay, but it's not recommended from the HIV program point of view. So I'm not going to say no to it because that's the country, that's what they do, but SD bioline is more specific, so that is what we use. Or the treponema specific tests are what we use. Thank you.
Good to know. I'm gonna look that up to see you know, how if it's utilized even, or are they still just basically using the VDRL? Okay. Question and answer is open to the audience. You can unmute yourself and ask the question. You can type it in the chat, but we have question and answer going on at this moment in time. I'm going to look in the chat to see if I see anything else. Just comments as comments saying comments. Thank you. And
yes, I'm looking at the comments from Cheryl saying the policemen need extra vitamin C. That's one thing that we use in our presentation, because you know you have to break it to the patients as real as possible for them to understand the importance of taking the medication. So your viral load, your CD4 count are the policemen who are at your windows and door, and the viral load is the speed at which the train is traveling. So the higher the viral load, the faster you get to death. The higher the CD4 count, the better protection you have.
Any other questions from the general audience? You can type it in the chat, or you can come off mute and you can ask.
I guess it was too much information for them. They are thinking about it, and they will post the question after, and Heather will reach out to me and I can. Yes, we are really working to eradicate this disease. Such a pity that our clients don't understand what we are trying to do, but we are hoping to get there.
I have another question. How much of the cutting, do you guys have access to the cutting edge medications? Because there's a few that they advertise here on TV that says that they can get the viral load down to being undetectable. So basically like a cure. I can't remember the name of it, the latest one that's out.
It's the same one that I'm talking about, the same tenolone dolutegravir, but okay. It is sold, it is branded in another name, but if you look at the 3 ingredients, it is the tenofovir, lamivudine, dolutegravir. Yes, it's really a miracle drug. It doesn't cure. However, the viral load, it reduces the viral load within weeks.
Yes, to basically undetectable, correct? Because it's like so, yes, so minuscule. Okay, good.
I see that Cheryl has her hand up.
I do. Thank you so much, Madam Presenter. Thank you very much, Madam Moderator. As we're going on, I know a few more people are thinking. So I was listening intently and saying to myself, boy, there's a lot of information. And I like when the experts are on hand. So the first question I had, I think the last one, you responded to it when I was saying, it sounds good what we want, but what do we have? But you gave us your statistics roll out properly. So you answered that quite fine. I think one of the first ones I had written, you may have answered it too, and I'm not sure. I think we had moved to HIV testing being a main part of the screening done when you're pregnant. Do we have other um, STIs that are part of the standard screening? And has anything been added maybe recently?
So antenatally, we screen only for HIV and syphilis as STI.
Okay. So the others would be a matter of personal choice and perhaps privately?
Personal choice. And they are not offered in the government sector. So they would have to do it privately.
Okay. All right. Thank you.
Welcome. Can I stop sharing now?
Yes, you may.
Thank you.
There is a question online. Can exclusive breastfeeding prevent a HIV mother from passing on the virus? But I thought that per your presentation, not that I'm taking over and answering, that it's not recommended to breastfeed.
All right, so it is not recommended, but it is thought that it can, and that is why in some countries that does happen. If the woman is going to exclusively breastfeed and have and is adherent to their ARVs, then it is allowed. But in Jamaica, it is not recommended for us. But there are some countries, once the woman is going to exclusively breastfeed, as in not mixing feed formula to the breastfeed, once they're going to exclusively breastfeed and their viral load is probably undetectable, then they are encouraged to. But in Jamaica, we do not.
Any more questions?
I have a comment that I want to express. If there are no more questions, I want to express my thanks to my colleague, Heather, for asking me to do the presentation. It has sharpened my skills. I can say I would have been doing some things like this over time, but it's a while that I have not done this. But I want to say thanks to the personnel on the team who sat throughout the presentation. I don't know if I did justice to it. However, thank you all for being so attentive. Thanks for being responsive. And as always, if it's something that I can manage, I'm always available to doing something like this again. Thanks a million.
You're welcome.
Yes, you're welcome. It was very enlightening, quite informative.
All right. So, Madam Denise, are you done?
Yes, I was just about to say I'm going to turn it back over to Madam President.
All right.
I was going to say I'm turning it back over to close.
Thank you so much, Madam Moderator. Wonderful job. And then thank you so much, Mrs. Johnson Wallace. You don't need to worry about if you did or didn't do justice. You gave us a whole lot to process, and lots of us are learning. So even if some of it we won't be using it daily, definitely we're able to share and pass it on. And I'm very proud of what we do. I have to share and tell you, as an international organization, when we go, I have the opportunity to go at any of the events, sometimes I think we do underestimate ourselves and what we bring to the table. as Jamaicans and as people in the Caribbean. And when we go, and so when I heard you reeling off your statistics, I'm like, well, when you said we were a little over and you said 2.04, and I said, oh man, look at that 0.4 right over there, just squeeze onto the 2. But we are doing an awesome job. And it is good to see that we are a part of the movement to have the elimination of the STIs from mother to child and facilitating safe deliveries, improving the health of the mummies, and certainly improving the health of the babies as they develop. So you did an awesome job. I really want to say thank you. I hope you're drinking some water because we had you talking for a long time. And I want to thank everybody who is listening attentively as well. I was saying to them over on YouTube, oh, you're quiet over here. But they were listening and they're saying you did an excellent presentation. So we really want to just say thank you once again. So as we close out, quickly, I just want to say congrats again to our winner for this evening's pre-game. We may have to start telling her she's not eligible either, right? Because she knows why. But it's great to participate and keep our brains active. So just as we've done, because today is our last evening for this week, we have 3 more sessions next week. We close our last IPC presentation on Monday the 25th, and on Wednesday and Thursday, we ask you to come back and join us for the 2 non-nursing sessions. We're going to talk about professionalism and we're going to talk about emotional intelligence. So just a little bit of an announcement. We had a little challenge and we are still having the 2 presentations, but I know you picked based on what we shared on the registration form. So professionalism will be our last presentation on Thursday and emotional intelligence will be on Wednesday instead. So it's still going to be both of them. If you registered for both, then you don't have a problem. Just in case anybody else again had wanted maybe just one, we will have to send out an announcement so they are able to understand that we're doing emotional intelligence on Wednesday and professionalism on Thursday. So just a little bit about Omega Kappa before you all disappear. And just to make sure, Madam Donita, don't leave just yet if you don't have to. We want to make sure. Yesterday, I was hearing wrong things, when the people were giving the right answer. So the other prize before we close off, really quick, there must be some questions. We were all listening. We must be paying attention. Okay. So instructions, everybody ready? You had your paper from before, Type your answers in the chat here on Zoom and over on YouTube land. All at the same time. So start typing, but don't click submit until... Can I
participate?
As a presenter? No, I'm sorry. I was going to give the disclaimer. You're on the moderator, still not eligible.
I didn't hear the rules, so
I don't reach it yet. Listen up, I soon tell you. So get your paper if you have it, or if you're just going to type in the chat, that's fine. But I'm asking you, when you type the answers one at a time, we have to scroll up and down to see who got all 3. So don't click the submit button until you type all of the answers, and then we can see if you got them right. Everybody's ready? So question 1, what is one of the most important or maybe the number 1 way to help with eliminating mother-to-child transmission of STIs? Second question, what is the other name that is used to describe mother-to-child transmission, right? And then the third one, what is the test that is no longer being used in the Jamaican government system? So you're supposed to be typing up, don't click submit yet. So listen again, just in case. First one, what is the most important or one of the number 1 ways in which we can help with eliminating mother-to-child transmission of STIs? Second one, what is the other name that is used to describe mother-to-child transmission? And 3, which test is it that is no longer used in the Jamaican government system? And so the moderator and the presenter are able to participate by giving the answers if they so wish, but they can't get the prize, unfortunately. All right. So I'm waiting to see all the things going up in the chat now. 3 responses. I'm giving you a minute really quick so we can be done with this part of it. And then I have 2 little things to tell you, and we're all free to have a wonderful evening. All right. So some people started submitting and I say 1 answer. We don't want any 1 answer. Anika, you put only 2 answers instead of 3. All right. That's Chantel. All right. All right. I see a couple more answers going up too. All right. Shanette, I see you. Over on YouTube, how are you doing over there? Any answers for us?
Can I put in the correct answer now after
30 seconds more and then you can put the
Okay.
answers. So we will know who it is that typed it first and won.
Yes.
Yes. All right, counting down, the 30 seconds going quickly. Anybody else was typing, type quick, because suppose the person who type already didn't get it right. Come, type quick. All right, 10, we're counting down, almost at 0. All right, Madam Presenter, go right ahead.
I'm coming, VRL. And it's not C, it's 4.
Wonderful. That's all right. We know the patois of it. It was the patois translator that changed it for you.
So it is really that the mother, they should get tested for HIV and syphilis.
You're right.
The term is vertical transmission, and we're not accepting VDRL.
VDRL. Wonderful. So that means
Shanette is the only one that came.
Wonderful. Congratulations, Madam Shanette. I am going to put back my number in the chat and you can send me a message so we can talk about your prize. Thank you so much for participating. And thank you, Madam Presenter. Awesome job. Those were the answers I had, but I wanted to make sure that I was really listening good. You understand? So thank you, ladies. Just 2 seconds more before we close off. We are the Omega Kappa chapter, and I know you want to hear a little bit more. Who are we before you saw this webinar? Some of you heard yesterday, some heard the day before. All I'm going to tell you today is that we are chapter 560 out of over 550 active chapters in Sigma Theta Tau. We are in over 100 countries, and all we are comprised of our nursing students and nursing leaders. So we are a group of nursing excellence bursting at the seams, and we're always seeking more persons to add because it's important. So every 2 years, that's how our organization operates. They have what they call a call to action by the president of the association. This time, they have made it an organizational call to action, and our president is encouraging us to be bold. That's the name of it. But why he's saying that, he's asking us, too often, nurses are not a part of what needs to be decided. Too often, nurses are only talking amongst nurses, and too often, we need to work on creating our own space at the table if we're not invited. So there are 3 areas he's asking us to step up and be very bold. Get the knowledge, get the information, because it ties into nursing, nurses, and healthcare. So he's saying, go and look at economics and see how we can operate and get this done, because the money is important in healthcare. It's a business. The technology, especially those of us here, boy, we've been waiting on electronic health records, for instance, for the longest of while, and conservation, our health is being more affected as we are damaging outside. So I'm just encouraging all of you to be bold, and I'm saying to you, just in case you want to hear a little bit more and you want to find out more about Omega Kappa itself and Sigma Theta Tau International, we have worked out that many people want to hear. So we're just inviting you. Next week, Tuesday, 1 single hour at 5:45 p.m. Jamaica time. We will tell you a little bit more about us and Sigma, and we will take all your questions and help you to be on your way to joining our awesome chapter. Let me rephrase that, our award-winning awesome chapter. We're only 2 years old, but we've been doing well. And so come out and hear. We have an induction at the end of May. And if you want to be in it, we're very happy to have you. So thank you again, Madam Presenter, Madam Moderator, fundraising committee who's putting this on, all of our participants. We could all be here, and if you weren't here, it wouldn't make any sense. And thank you especially to those who join us over on YouTube. We encourage you, go and like and subscribe. We have lots of information over there and more will come. Have a great rest of your evening and see you all on Monday. Feel free to open your microphones and say bye as we go.
Bye.
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 Bye.